How do we position our work in the context of the United Kingdom's Memorandum of Understanding on Conversion Therapy? For those of you not so inspired by such documents, if I can by summary say that this is a document that has been signed by 14 of the largest UK professional mental health bodies, and it is presented as a consensus document of some importance. It followed the consensus statement on conversion therapy, which included various mental health bodies and also campaigning groups who would be described as from the gay lobby. So Stonewall, Pink Therapy, which is a therapeutic body, were also a part of that. But you'll have noticed that the consensus is around the notion of conversion therapy. Now, I must say, I don't know anybody who calls themselves a conversion therapist in the United Kingdom. In fact, I don't even know any people who call themselves reparative therapists in the generic or in the specific sense of the word. So we have a document here that is a consensus that is now being presented as the professional document that the professional mental health bodies subscribe to. I'm not going to stick on that level because you can find out the information in terms of its content, and I think you do have a copy of it in your pack, etc. But I have a dilemma, and I'll just relate this dilemma to you so that we can, perhaps you'd be able to help us, and me certainly, strategize around all of this. A couple of years ago, I approached the United Kingdom Council for Psychotherapy and told them that I was in my third year of psychodrama psychotherapy training. Psychodrama is an action group method. It's group psychotherapy. It's therapy that is, Freud said, tell me. Moreno said, show me. Most of us are not able to articulate the pain that we experience from childhood. And many therapists make assumptions, I suggest, about a client's ability to be able to articulate their understanding of their own pain. Psychodrama works in a completely different way to elicit that. So it's more visible or more present for a client, and then it's possible to work on all of those issues. So I approached the United Kingdom Council for Psychotherapy and told them that I had a problem with some of the statements that they were making about therapy in this area. And I asked them for permission to engage with them. The response I got was, yes, you may, and here's the address to send your submission. So I sent my submission, which took a great deal of thought and time, I must say, only to receive a response which said, I'm going on holiday, we have taken advice, I think you should change your professional orientation because you're not suited to do therapeutic work if you hold the idea that people can move away from homosexuality. And that's really where it began. To cut a long story short, after 2 BBC interviews where I expressed the view that autonomous individuals should have the freedom to access professional help to explore the possibility of change, I found myself outside of my training institution. In fact, before I left the studio, I received an email to say that I was under investigation. A week later, I was removed from my training institution and from the professional membership on the grounds of public safety. A year later, after having been offered a meeting by Skype, which I refused, I was removed from the Psychodrama Association following an unsuccessful appeal. I'm not really telling you that to gain sympathy, because I have learned that there is life beyond the professional body, and I'm going in a different direction here. But it does present a significant problem for numbers of genuine psychotherapists and counselors in our country. If you don't have professional membership, you will not get professional indemnity insurance. If you are on the outside of a professional body, you will not get the standard collegiality in terms of a supervisor. So it leaves professionals very much on the outside of the family of therapists and counselors. So that's my situation. And as I say, I'll tell you a bit about a new direction that I am going in. I have subsequently attempted to engage the Association of Christian Counselors, who hold a different point of view to myself, and John will put that in context and explain it more fully in a few minutes. So the question is, folks, how do we present ourselves as connected professionals? People like me, people like Leslie Pilkington are on the outside. And there are many other people teetering on the edge. I won't say looking over their shoulders, but you get my meaning. It's a difficult situation for many, many people. On a positive note, having just returned from Germany, where we had a successful conference led by folks over there. There were therapists from Hungary, from the Czech Republic, from Macedonia, 7 or 8 European nations, all concerned with the same issue. And I think within each of us, there is a realization that something new needs to happen. So for me, in partnership with the Alliance for Therapeutic Choice, why reinvent the wheel? They have great expertise, in my opinion. There's huge expertise among therapists all over the world. For me, I think it's time to consider alternative structures. So if you hear me say on the occasional media opportunities that I have that I think it's time to look at alternative structures, I hope you will understand it's not out of a spirit of defiance. It is out of a necessity to find new ways of expressing ourselves, given that we are no longer welcome in the existing professional organizations. And I suppose what I'm asking for is help in knowing how to do that. And I'm so encouraged by all of those who are on the platform next to me, who in their own ways, perhaps from different points of view, have a major contribution in this field. And I want to learn and ask for your help for those of us here who feel that it is important to be above the parapet. And I want to honor all of those who work below the parapet, or all of those who have to reinvent themselves to be cautious and to work in a way that it works for them. The Lord has called us and Core Issues Trust in a different direction. I'm of the view that for me, it's important to hold the flag up. You know, it might be a little flag, but if there's no flag at all, it means that there's an erosion of freedom in a certain sense. So I hope, folks, that gives you a broad perspective on certainly where I am. Forgive me that perhaps that sounds personalized, but hopefully you'll understand where I've come from. I have tried to engage the Professional Standards Authority, which regulates the 6 professional, or I don't know what you call them now, the people like the General Medical Council, which itself regulates the Royal College of Psychiatrists. I've tried to engage them. You're very welcome to see the correspondence. I don't see a consistent internal logic in terms of the way they respond to this question. I keep asking them, yes, I do understand you have an equalities duty and responsibility to those who are LGBTI. My question is, what is your equalities duty to those who come from an ex-gay position? Because of all the faithful work of Christian Concern in the legal cases that we've been battling our way through with respect to example for the bus case, the courts have at least affirmed the fact that discrimination on the grounds of sexual orientation is always illegal, including discrimination against people who see themselves as ex-gay. In other words, the court was saying that sexual orientation or discrimination on the grounds of sexual orientation is always wrong, and it doesn't matter whether that sexual orientation is past or present, perceived or actual. You can't discriminate on those grounds. I feel those of us who do not wish to identify as homosexual, although we have experienced the feelings, are being discriminated against. So there's a great big battle that's going on. So we've gone to the Professional Standards Agency. Others in an independent way have gone to the United Kingdom Council for Psychotherapy. That's an ongoing complaint with the PSA that is currently being investigated. And then through Dermot and Dr. Peter May, the General Medical Council have also received a complaint in the last week or so, and they'll be telling you more about it. So this is just to say that as boring as it is, all of that stuff is going on in the background. So please know, the duck is really swimming under the water with its legs. We're trying to make progress here and push forward and clarify the situation and fight for what we believe is right. So thank you for the time. And
I wanted to share with you, I think, at least some observations we've had from working within the American context that may have some applicability to you as you are dealing with these issues. So the stated goals of the memorandum, they are to ensure that the public is well informed about the evidence and risks of conversion therapy, to ensure that healthcare professionals and psychological therapists are aware of the ethical issues relating to conversion therapy, to ensure new and existing psychological therapists are appropriately trained to competently deal with requests for conversion therapy and to support clients in distress, and to ensure professionals from across the healthcare and psychological professions work together to promote the public interest. Now, in general, the Alliance would support these goals and objectives, at least at face value. I think the problems are in the details of working that out and what I think are some differences in how we would understand this. So, I've outlined some areas I think we can think about how we can position ourselves. In the professional arena, we need to practice with high ethical standards, particularly if you're going to be in this area at all. You have to go above and beyond the normal standard, I think. So Things like informed consent, very important, document this. There has to be no hint of coercion in your care, and avoid non-mainstream interventions. Of course, be guided by the ethical standards of your respective field, and I would even recommend you be familiar with the Alliance practice guidelines. If you go onto the Alliance and the North Institute website, you can link to our practice guidelines for working with therapeutically with unwanted same-sex attractions and behaviors. I think, too, we can also look at how we define our work. And I'm more and more thinking about a trans-theoretical therapy approach rather than something like conversion therapy. Unfortunately, the term has been very demonized to the point where it's probably just functioning as a foil to a straw argument in public discourse these days. And in defining it, I think we can conclude that we use standard interventions from various modalities that can assist in the facilitation of change for some individuals. I think we require opponents to define what they think conversion therapy is. I mean, that's why I asked the question earlier, because I'm really interested. Because of my experience, there's just so much disinformation out there. In doing that, we can make clear that what is being opposed oftentimes is not some strange type of therapy, but ultimately it's the client's goal of change and the counselor's acceptance of that goal. I think that's where an objection ultimately lies. And we can also professionally try to expand the scope of what cultural diversity means. Diversity includes clients whose faith and/or values lead them to pursue change, as well as those who have experienced change. Shouldn't diversity include them? So that cultural competency must include an allowance for change-oriented goals, and counselors must maintain and manage their bias against such clients. How do we position ourselves scientifically? Well, I think we can challenge the Memorandum of Understanding where its scientific claims are incomplete or otherwise not justifiable, such as in the issue of the harmfulness of professional SOCI. We can emphasize that we support further research on SOCI, sexual orientation change efforts, while the MOU prevents this. And my question to some of these folks is, how can they simultaneously demand research to support SOCI while at the same time trying to prohibit its practice? It seems like you're speaking out of both sides of your mouth. Which is it? And thirdly, stress the importance of ideological diversity within science to ascertaining truth and making good public policy. And let me give you, I always do this, I have to do this because I think it's so very instructive, and if you've heard this before, bear with me, but just a few examples of the lack of ideological diversity, certainly in American-based mental health associations, and I assume probably in the UK too. But for instance, the primary document that started this all was the APA, American Psychological Association's task force report on appropriate therapeutic responses to sexual orientation change. That task force, many qualified conservative psychologists were nominated to serve on that task force. All of them were rejected. Very qualified people from Wheaton, Regent College. Only psychologists that were unsympathetic to change efforts were appointed. 5 of those 6 task force members were LGBT identified. Nothing wrong with that necessarily in this topic, but there was no counter voice in creating this report. And basically the APA said, those voices of conservatives, that they don't fit our worldview, so we can't include you. And literally use those terms. Also, the American Psychological Association in 2011, you've got to consider the date, their Council of Representatives, 157-member leadership body of the APA, they voted 157-0 to support same-sex marriage initiatives. Now, good people can differ about same-sex marriage, but 157-0, not one vote that supported a traditional understanding of marriage. That would be considered a statistically impossible lack of diversity. Just last November, the National Association of Social Workers in America endorsed 169 candidates in the federal elections. And out of those 169 candidates, 169 were from the Democratic Party, which is the left of center party in America. And finally, the American Medical Association, if you're familiar with them, just point out that they've been hemorrhaging members for a little while now due to their support of a lot of left of center social policies, and the AMA represents less than 20% of doctors in the USA now. So when you see some of these, well, the AMA says this, AMA says that, keep in mind, they may not even represent the majority of professionals in the country. This is a great quote, and there it is. I got it mixed up. This is an article, the reference is in the back, and basically, Haidt is one of the authors in this article, but they say the lack of diversity causes problems for the scientific process, primarily in areas related to the political concerns of the left, including sexual orientation, as well as in areas where conservatives themselves are studied, such as in moral and political psychology. We argue that the collective efforts of researchers in politically charged areas may fail to converge upon the truth when there are too few or no non-liberal researchers to raise questions and frame hypotheses in alternative ways. In this way, certain assumptions, theories, and findings, you may insert perhaps the gay gene, can become the entrenched wisdom in a field, not because they are correct, but because they have consistently undergone less scrutiny. When most people in a field share the same confirmation bias, that field is at higher risk of reaching unjustified conclusions. And I think that's exactly what's happening. Now, we can also position ourselves morally, and this is where I'm a big fan of a guy named Jonathan Haidt. He's a professor at the New York University, and he has developed something called moral foundations theory. If you're interested in understanding the debates and the conflicts and the culture from a moral perspective, I'd recommend you read his work from 2012. The citation will be in the back. I'll put it on the screen. And he basically discovered cross-culturally that there are 6 moral foundations from which people develop their intuitive sense of morality. He says it's like a palate, taste buds. And these vary from person to person, but the 6 are harm and care, fairness and reciprocity, oppression and liberty, in-group loyalty, authority, respect, and purity and sanctity, which is often where religious concerns come into play. And what he's identified is that liberals, left of center, tend to create a morality relying primarily on the care and harm foundation, with additional support from the fairness and cheating and liberty oppression foundations. Whereas conservatives, especially religious conservatives, he says, use all 6 foundations, including loyalty, betrayal, authority, subversion, and sanctity, degradation. In the interest of time, I won't get into all the details of that, but you can certainly look it up in terms of the definition specifically of these foundations. But what this means, pictorially, is this. You have the moral worldview of someone left of center tends to be in that smaller circle. And those 3 foundations Haidt terms the individualizing foundations because they emphasize rights and the rights and welfare of individuals. So when you listen to political talk, you listen to talk in the culture, you'll pick up on these foundations. It's very, very enlightening. Now, conservatives tend to we understand these individualizing foundations, but we tend to have a broader spectrum of moral taste that include the binding foundations, these are the 3, which emphasize group behavior, loyalty, duty, and self-control. So we tend to have concern with what's happening for our society, our functioning as a group, as a civilization. And obviously, it can be weighted differently for different people, but this is how his research seems to be showing a general difference, a pattern of difference. So that might mean in terms of how we use religious language. And I think in general, religious moral justifications are not going to sway secular authorities, you see, who may determine our fate. And therefore, it's probably better to not use this language if we're speaking to politicians necessarily, or we can use it, but I think we need to also find language that doesn't rely on the binding foundations. Like we talk about autonomous choices and self-determination. Those have a more resonance than this particular passage of Scripture. Not that that isn't important, but you understand what I'm saying. We need to be wise about these things. And when we don't, see, quoting a verse, as good as that may be, to a liberal person, that may have no moral authority. In fact, that may seem immoral, where to us it feels very moral, because they occupy a different moral universe in some ways. Also, toilet to tap. I put that in a quick little story. You know what? I don't know if I'm going to go down that road in the interest of time. If I have time, I'll come back to it. But I really wanted to share one other thing. And toilet to tap is just really talking about how important language is. And if you find short, pithy statements, you can actually sway culture. You can sway the social reality. Whereas if you try long explanations and biblical exegesis, people are going to blank over. So if I have time, I'll go back, but I may not. Let me move on. So politically, I really wanted to, I don't know how this would translate necessarily into the UK context, but I really wanted to share this. And if I can do this in 2 minutes, I'll be very happy. But in 2014, the Washington State Legislature debated a bill prohibiting professional association with minors similar to the law passed in California. When it was reintroduced again in 2015, the language was changed only to prohibit aversive forms of SOCI, which have been featured by SOCI opponents as the face of SOCI and the reason to prohibit professional counseling for change for minors. The bill said this: it prohibits aversion therapy, which means a practice, treatment, or therapy involving electric shock, extreme temperatures, prolonged isolation, chemically induced nausea or vomiting, assault, or other procedures intended to cause pain, discomfort, or unpleasant sensations to the client or patient. But prohibited aversion therapy does not include those practices, treatments, or therapies that are within the standards of practice for license holders under this chapter as provided in department rules. So basically, it's taking out a lot of the argument against SOCI, as I'm particularly hearing, in terms of aversive treatments. And what was interesting was that this language had bipartisan support at first, but then something happened. The same people who spent the last year talking about the need to protect children from ice baths and shock therapy suddenly and strongly opposed a bill specifically designed for that purpose. What was the problem? The bill didn't go far enough. It must restrict talk therapy, they said. Last year, not a word was uttered about the need to ban talk therapy because everyone was so horrified by the stories of involuntary shock therapy. All they talked about was the need to protect kids from child abuse. But now that they have been given the chance to stop involuntary shock therapy without the ability to regulate conversations, suddenly shock therapy isn't such a big deal. There are two things we can learn from this recent development. First, advocates of this bill have always been mostly interested in prohibiting conversations they dislike, not stopping physical forms of child abuse everyone opposes. The attempt to focus on stories of abuse was just part of the bait and switch. People suspected as much before, but now they have admitted it. Second, and maybe more important, the fact that they are willing to oppose a bill to stop child abuse in the hopes that they can pass a bill to ban conversations illustrates the depth of their conviction about this issue. From their perspective, telling kids same-sex attraction is not necessarily permanent is child abuse. The harm of involuntary shock therapy and the harm of a child being told change is possible are the same. If this tactic is successful, it won't just be the therapists who are affected in the end.
Inevitably, commenting on this memorandum, we're going to cover similar points and we'll have different perspectives on it. Mine comes from a medical perspective as a retired GP. This memorandum looks very professional, but I think it's shot through with ambiguities, and I think it's fundamentally flawed. For ambiguities, we've already considered conversion therapy. Now, I think this is used like a bogeyman. It's discussed as though it's a single discrete entity. I looked up bogeyman in Wikipedia and found that a bogeyman is a common allusion to a mythical creature used by adults to frighten bad children into good behavior. This monster has no specific appearance and conceptions about it can vary drastically from household to household within the same community. In many cases, it has no set appearance in the mind of an adult or a child, but is simply a non-specific embodiment of terror. Conversion therapy is a bogeyman. There's a footnote in the memorandum which takes us to some small print which says that this is an umbrella term. It's a type for a type of talking therapy or activity which attempts to change sexual orientation or reduce attraction to others of the same sex. And in those terms, it covers everything, from electrical and chemically induced aversion therapy of a bygone age, hopefully, to modern techniques, including cognitive behavioral therapy. Now, if it is all-embracing, are all these therapies equally dreadful? The foundation of this memorandum lies in paragraph 2, in what it calls an informed position, which clearly means an underlying assumption. And the assumption is this: to try to change or alter sexual orientation through psychological therapies is unethical and, 2, potentially harmful. Now, if that foundation collapses, the rest of the memorandum's a puff of wind. It all hangs on those two things being true. So let's take the second issue first. Are these therapies potentially harmful? Now, it's a medical truism that every therapy that has an effect has a side effect. And recently we've been learning that even paracetamol, not just in overdose, but in normal doses taken too much over the years, can be lethal. Does this stop doctors from taking paracetamol? Or from recommending it to patients? No, of course not. In normal doses, the risks are very small, but it should be used sparingly. So we need to be very clear what the dangers actually are. Is therapy more dangerous than no therapy? Now, we know there's a suicide risk with therapy. Suicide's a common cause of death in young men. Has anyone compared the suicide risk with no therapy to the suicide risk attached to having therapy or to having gay affirming therapy, which now appears to be the only therapy that is being promoted? So a potential for harm is always there, even cognitive behavioral therapy. Some clients might embark on new activities as a result of that, leading to an accident or perhaps a coronary walking up a hill. Would we blame cognitive behavioral therapy for such a negative effect? So we need to know where the harm lies. Dermot O'Callaghan's repeatedly asked the UK Council of Psychotherapy to provide evidence that such talking therapies are not potentially harmful, but actually harmful. And they have persistently and repeatedly refused to answer the question, which is very odd. If there's good scientific evidence out there, why not tell us about it? Senior advisor at the White House has just announced that there is overwhelming scientific evidence that conversion therapy can cause substantial harm. Terrifying, isn't it? Well, why not tell us where the evidence can be found? Surely this is an emperor or perhaps a president who has no clothes. And if they cannot document the harm, can they answer the other question? Why is this treatment unethical? Now, the ethical offence must lie in the goal to be achieved rather than the means of achieving it. It cannot lie in talking therapies themselves. It could lie in the administration of talking therapies if the patient doesn't request it or has been shamed by the therapist into pursuing it. But as has been well explained to us, therapists are under moral obligation to respond to their patients' wishes and beliefs. And they must also discuss in advance both the desired and the likely outcomes of therapy. So there's no scope for rash promises. Conversion therapy suggests a Damascus Road experience, radical change, a complete turnaround. Well, very few people experience that. What might be achieved is help for people who want it in managing or modifying intrusive desires to render them less powerful and less disruptive in their lives. It's unethical to help somebody. Is it unethical to help somebody modify sexual desires if they request it? Well, therapists attempt to do it regularly for people with adulterous desires or pornographic addiction that we've been hearing about, or even paedophilia. So is so-called sexual orientation some sacred turf that must not be walked upon? The memorandum claims that there's no good evidence that therapy works, which would call into question the ethics of using it. But the key word is good evidence, meaning scientifically rigorous evidence. And such research has never been done. So there's no good evidence that it works, and there's no good evidence that it doesn't work either. We just don't know. And such trials are very expensive. And many surgical and nursing procedures have never been tested with this sort of rigorous double-blind trials. They're decided on a common sense basis. Consider, for instance, appendicitis. No one's ever done a trial. We haven't 500 people with an acute appendix and 500 in another group you decide not to treat. But you'd have to open them up. They'd have to have an anaesthetic so that they've got the placebo effect. They've had it removed, but the inflamed appendix is left there. Has anyone done that sort of research? No, of course not. And that sort of thing runs through a lot of procedures in the medical world. Of course, if the original statements of the Royal College of Psychiatrists are to be believed, sexual orientation is both genetically determined and unchangeable. Now, it's widely known that these things are not true. And so we complain to the college. And what do they say? Well, after 2 months, the college registrar acknowledged our letter and flatly refused to discuss it. And that's the last communication we've had from them. As A.A. Milne would have put it, and that, said John, is that. Well, almost that, except that 10 months later, they changed their public statement, conceding that sexual orientation is neither innate nor is it immutable. And so the scientific basis for this memorandum, it seems to me, is now shot. A recent paper on the causes of same-sex attraction, actually published this month by research scientists Dennis Alexander and Nell Whiteway in the April edition of Christians and Science and Christian Belief, which is the Journal of Christians in Science organization. They put it like this, and it's a long and detailed argument, and on the website there is a more detailed argument, presentation of it that you can get hold of. But they conclude, in men, genetic influences on same-sex attraction cannot be ruled out, although any genetic variants that do influence same-sex attraction will be of small effect, and there is no single gay gene. Furthermore, there's ample evidence that orientation can change, demonstrated particularly by Lisa Diamond's research. Change is more common in women than in men, and is much more common among male adolescents than in older men. And this probably has a lot to do with neuroplasticity of the brain. When adolescent desires, reinforced by repeated pleasurable experiences at a crucial stage in their development, lay down neural pathways and response mechanisms which in later life are very difficult to eradicate. And it does young people no favor at all, President Obama, please take note, especially when HIV rates are rocketing in young people, to tell them that the orientation they experience in their teens is fixed for life. when it clearly is not. And now they're going to be banned from getting any professional help. Now, by their own admission, the college statements are frankly wrong. Now, if this was merely a mistake, why wouldn't they just thank us for pointing it out and correct it immediately? So were these errors actually made in ignorance, because they just know less about it than mortals like myself? Or was it deliberate intention to propagate an agenda? Recently I spoke about this to a senior doctor, a fellow of 2 Royal Colleges, and he said he thought that the behaviour of the college was disgraceful and that we should report the officers of the college to the General Medical Council. So Dermot and I have written a 14-page complaint against the former president of the Royal College of Psychiatrists, the college registrar, and Professor Michael King, who's the principal author of the college statements, and that has now been delivered to the General Medical Council, listing more than 20 examples of their failure to follow the GMC advice in their booklet, Good Medical Practice. And we await their verdict with interest. Thank you.
My title is A Church Perspective on how to position our work, that's the work of the professionals, in the context of the memorandum. And the first thing to realize, I think, is that there are 2 streams of therapeutic work available to a client who would like help in reducing same-sex attraction. There's the professionally mediated therapy that we've heard about, and there's also parachurch or church-based activities. And it's easy to forget this division, but it is an important one, because it's the professionally trained therapists who are being targeted by the Memorandum of Understanding. Perhaps the powers that be assume that demand for change therapy will fizzle out when the professionals are all dragooned into offering only gay affirmative therapy. But I don't think this is very likely. Indeed, I think the opposite is likely to happen. When people who want help to reduce same-sex attraction are turned away by the professionals, they'll turn in greater numbers to church-based ministries. And I'm tempted to anticipate and to fear that churches which offer such ministries are likely to be targeted by activists in the future. But I'm not going to go there today, because I've taken my title to mean how should the professionals position their work. Now, in principle, the work of the professionals in this field will dry up. In a sense, there'll be nothing left to position. But for the sake of science and of society, the professionals need to organize themselves to push back against this unjustified tyranny. Part of the fight will be by demanding evidence, and we've touched on this already. Evidence of harm and evidence that therapy doesn't work. Now, we know that this evidence doesn't exist, and the professionals should shout this from the rooftops and should equip the churches to ask questions. We need to use arguments that reach into the heart as well as into the head. The one I keep coming back to is the married man or woman with children who wants help to reduce same-sex attraction. And this example is very powerful because it's clearly a good cause. The married man example spikes the guns of the opposition very effectively, because their doctrine is that gay is good and that therefore to try to change is bad. But nobody can say that a married man's desire to reduce his same-sex attraction is bad. He wants to hold his family together. That's good. Last Thursday, Dr. Joseph Nicolosi was on Newsnight on the Obama announcement, and he defended himself by saying, "We help people to be who they want to be." And his opponent, Dr. Jessen, jumped up and he said, "No, you help people to be what society wants them to be." And he didn't answer that, or perhaps didn't have an opportunity, but isn't that an arrogant statement? But if he had said, "Here's a married man, we help this man to stay with his wife and kids," then the other argument would have fallen flat completely. So how can the professionals work more closely with the churches? Surely they must take on an educative role. Sadly, the churches don't have the skills to stand up against the gay lobby at present. The professionals need to educate them to understand what's at stake, that what's at stake here is not that James loves John, and therefore why should they not be allowed to marry? What's at stake is about replacing one worldview, the worldview that we've grown up with something quite different. The Memorandum of Understanding states that, and I quote, "The aim of the commitments contained in this MOU is to ensure that the public are well informed about the evidence and risks of conversion therapy." Now, we've got to take them up on this. They want to give us evidence about the risks and they want to inform us about the evidence and risks. We want a science that's free of ideology. We want a science that's based on evidence. Are they now offering to show us evidence of the claimed risks and ineffectiveness? If they are, why have they refused to share it with us despite our repeated demands? And what do they make of the statement of the American Psychological Association that, and I quote, "There are no scientifically rigorous studies of recent sexual orientation change efforts that would enable us to make a definitive statement about whether recent SOCE is safe or harmful, and for whom." In other words, there's no evidence to justify banning these therapies. So although they insist that their science is evidence-based, the new science is not based on evidence, but on ideology. Now, the UKCP is a classic case that Peter has just referred to, because a couple of years ago, I asked their chief executive, Mr. David Pink, where I might find the, quote, "overwhelming evidence" that they claim of harm. And I received a polite reply, but no answer to my question. So the UKCP has declined to offer any evidence in support of its contention that therapy to reduce same-sex attractions is harmful. And it's the UKCP that has pulled together this Memorandum of Understanding document. And then, just remember that I'm going to put 4 fingers up one after the other. First of all, no evidence was offered. Secondly, Dr. Di Hodgson, the chair of the UKCP's Diversity and Social Responsibility Committee, incautiously admitted on Radio 4, "I think there's very conflicting evidence." So we, she says, have taken a view in a way which is regardless of the scientific findings. We still believe that it is unethical to agree to or work towards changing someone's sexual orientation through psychotherapy. So the UKCP says, first, there's overwhelming evidence. Then it declines to specify any evidence. Then it says there's conflicting evidence. And then it says, we've taken a position that doesn't require any evidence. Now, anybody with a scientific understanding should shudder at such a notion. Every thinking person should wake up. The churches need to press the UKCP and other professional bodies very hard on this point. Their position is anti-science, but the churches won't do this unless the professionals give them some backbone. So I'm going to close now with reminding you of 4 points that I've made. One final point for the professionals to emphasize is that the memorandum will create a situation similar, sadly, to backstreet abortions, where therapists will emerge to meet the client demand because the client demand will surely not go away. This can't be good. So the memorandum arguably will increase rather than reduce the risk of harm. So my 4 key points: use a family man or a similar practical example to educate the churches. 2, help the churches to realize that this is not about James and John. It's about taking on a whole new worldview. 3, challenge the mental health professional bodies to produce their evidence of harm and ineffectiveness, which the APA couldn't find. And 4th, warn of the backstreet abortion risks. Thank you, ladies and gentlemen.